Hi, everybody, and welcome to today's Family Medicine Grand Rounds for March 9th. We want to make sure that we do go ahead and provide you the information for the CME that is being credited this session. So the activity code is listed there for you, and please make sure that you do register before midnight tonight. If we can go to the next slide, I'll just show you here quickly what that will look like. So in order to register for the CME credit, if you have not already done so, please make sure that you text your email address to the number provided there. And once you have texted your email address, you can then start using the activity code for this session, which is listed there, 100-87621. So if you are interested in credit for today's session, please make sure that you do register before midnight tonight. But if you have any issues, you can reach out to me. Next slide. So for today's presentation, we want to make sure that you have muted your microphone as we go ahead and get started. And if you could just please remember to be attentive and engaged in the session. We are going to go ahead and take questions. If you want to put those in the chat box, we will take a look at those at the end. But also I will be putting in the evaluation link once we get closer to the end of the presentation as well. So if you could help us out with that too. Next slide. So just as a reminder, this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and our department's mission statement is listed there for you. Next slide. CME transcripts. If you do want to view your CME transcript, you'll need to go to the UTSCA CME website, which is listed there. But if you're having any issues with that, please feel free to reach out to myself or to the CME office. Next slide. If you are looking to receive AAFP credit, you'll also need that transcript that was just shown. So you can claim credit, but keep in mind that you'll need that transcript from the CME office. So any questions with that, you can also reach out to me or to the AAFP. Next slide. We also want to make sure that we do mention that it is our goal of these FCM Grand Rounds presentations to address the nationally established physician core competencies that you see listed here. So just please keep that in mind. Next slide. We also have to mention that Dr. Martinez has no financial relationships with ineligible companies to disclose. Next slide. So today we have presenting to us from UT Health San Antonio, we have Dr. Roberto Martinez. He's an assistant professor of plastics and reconstructive surgery. And his topic for today is common wrist problems in the primary care setting. So I'll let him get started with his presentation.
Thank you for that introduction. I'm grateful for the opportunity to come and talk about wrist problems in the primary care setting. I recently completed my hand and upper extremity fellowship at the Hand Center in San Antonio last year, and I started practice at UT in September. So I'm new on the block, and I haven't gotten a chance to meet very many people, but I'm hopeful that this could be a good introduction. I just also wanted to mention that I have a clinic out in Chavano in the PCC, so I'm happy to take any questions from providers that are out there on Mondays. So as Nicole mentioned, today we'll be discussing common wrist problems in the primary care setting with our main objectives of being able to identify common causes of wrist pain, as well as elaborate on the diagnostic workup for such and apply working knowledge of both the non-surgical and surgical treatment options. As with most patients who present to the clinic with pain of the hand or wrist, a focused exam, including range of motion, grip strength, and two-point discrimination is always the first step. But after gathering that initial data, I find that the easiest way to come up with a quick differential diagnosis is to divide the wrist into radial and ulnar sides, radial being the side with the thumb, ulnar with the pinky. Common pathologies affecting the radial side of the wrist include radius fractures, scaphoid fractures, de Quervain's tenosynovitis, STT arthritis, CMC arthritis. On the ulnar side, we can have ulnar impaction syndrome, DRJ instability, ECU tendonitis, TFCC injury, and a myriad of other conditions. And so when I initially signed up to do this Grand Rounds, I wanted to touch on all of those, but I realized very quickly that this is a very large topic and I wouldn't be able to do it justice to describe all of those things. So instead, I wanted to pivot my focus to the two most commonly encountered wrist fractures, the distal radius and scaphoid fractures. So I'll begin with a case presentation. This is a patient that I took care of during fellowship. He's a 49-year-old chronically ill gentleman with hypertension, wheelchair bound on hemodialysis, who presented to our clinic about 9 months after sustaining a fallen and outstretched hand. He had the misfortune of injuring himself during the height of the pandemic and presented to an outside facility where he was placed in a splint and told to follow up with his primary care physician. So his care was significantly delayed, and about, I think it was 2 months after his injury, he eventually followed up with his primary care doctor with a wrist that looked like this and a complaint of decreased range of motion and grip strength. You can see on the video on the right, he actually had a fair amount of finger range of motion, but had almost no grip strength or wrist range of motion. So he came to us with those complaints. And so as with most bones, the first step for almost all providers is an AP and a lateral. And I think this is a perfect example of why an understanding of the acute pathology of wrist fractures, and specifically distal radius fractures, leads to an understanding of the rationale for surgery and the long-term sequelae we're trying to avoid. So in beginning the diagnostic workup with these patients, there's one rule. You always get at least 2 views of whatever it is you're trying to study. Failing to get the appropriate perspective leads to incorrect assumptions. And granted, there will always be scenarios where you need additional views, but for example, as in the case of a scaphoid fracture we'll talk about later, but 2 views is always a reasonable starting point. So here we have a PA and a lateral of the wrist. There are plenty of systematic ways to look at an x-ray, but however you choose to do it in that way every time. Personally, I like to begin proximally and with the radius and ulna, as they're larger bones and easier to identify, obviously. When assessing the radius, there are 3 parameters to check, including on the left, volar tilt, in the middle, radial inclination, and to the right, ulnar variance, which is also a surrogate for radial height. And this refers to the relative relationship of the articular surfaces between the distal radius as well as the ulna. And though all 3 of these are important in assessment and assessment of injury as well as reduction, in the context of distal radius fractures in the sequelae, I think that ulnar variance is by far the most important criterion to assess for on x-rays. There are 8 carpal bones arranged in 2 rows, beginning radially. The proximal row is comprised of the scaphoid, the lunate, and the triquetrum. Distally, we have the trapezium, trapezoid, capate, and hamate. Radiographically, and depicted by the red lines on the left, there are 3 arcs used in the assessment of normal carpal alignment, referred to as Galula's lines. The first arc on the left, denoted by the proximal solid red line, is a smooth curve outlining the proximal convexities of the scaphoid, lunate, and triquetrum. The second middle dashed line traces the distal concave surfaces of the same bone, and the third line, the thinner dotted line, follows the main proximal curvatures of the capitate and the hamate. These carpal bones should have smooth and rounded edges. There should be no step-offs, and disrupted arcs, as demonstrated on the right, indicate either a ligamentous injury or fracture. There are an overwhelming number of classification types and subtypes for distal radius fractures. For example, the AO classification, which is generally considered the authority organization for the management of traumatic injuries in orthopedics, has 27 subtypes for distal radius fractures. There's also the Frickman classification that is, in my opinion, entirely nonsensical and random, and then the Fernandez and Malone classifications. But I think the most practical classification system that's been published is the Mayo classification system. It essentially groups these fractures into extra-articular fractures, meaning the fracture does not cross into the joint line, and intra-articular fractures of progressively worsening severity, types 2, types 3, and types 4. So another case presentation. This is a patient I had a couple weeks ago that underwent surgery with me. He's a 65-year-old male who was helping his son hang up a light and fell from about 10 feet onto the floor off of a ladder. Now that we've touched upon interpretation of radiographs, if there's anyone that wants to take a crack at the x-ray, I'll let somebody chime in. If not, I'm happy to go through it and discuss my rationale for proceeding with surgery. No. Yeah. So this is kind of a difficult X-ray to interpret if you haven't looked at many of these, but immediately you can tell in the middle of the screen, as I alluded to, radial height and ulnar variance is by far the most important parameter to assess on X-ray. You can see that he's clearly got a ulnar positive variance, meaning that the articular surface of his ulna is much further distal than the articular surface of the radius, owing to the probably axial load he sustained when he fell off the ladder. The left image demonstrates pretty significant dorsal comminution and dorsal angulation. Really anything greater than 10 angles is not acceptable surgically, and you can tell he's got about 45 to 50 degrees with a large fragment that is broken off of the dorsal aspect of the articular surface. And so in assessing these patients, once you look at the X-rays, there are three common questions that guide my diagnostic and treatment algorithms. So namely, one, who needs an operation? Why do they need an operation? And what long-term sequelae might occur if they do or do not have an operation? Before proceeding to comparing and contrasting operative and non-operative options, I think defining what non-operative treatment is useful. I stress this to all of our residents, and it was beat into my head when I was a fellow at the Hand Center. Non-operative treatment is not a passive treatment; it's an active treatment. You reduce the radius. You place a patient in either a short or a long arm cast, depending on their DRUJ instability. So a long arm cast crossing the elbow is required for radius fractures that have instability of the DRUJ joint, which you can feel on exam. So you put them in a cast, you bring them in continually once a week for repeat X-rays to assess if they've had continued loss of radial height. As I mentioned, that's at least in my algorithm, the most important parameter to assess before proceeding with surgery. Operative treatment in this era of surgical options is mostly volar plate fixation. Other options are K-wires or external fixation in the case of high velocity injuries, but it's very unlikely that we'll see any of those in clinic. And in helping to answer the question of who needs an operation, last year, the American Academy of Orthopedics and Society for Surgery of the Hand published an updated guideline on the management of distal radius fractures. Most of these guidelines and studies in general will separate patients into geriatric age, defined as patients greater than 65 years old, and non-geriatric patients, because it has implications for outcomes as well as treatment. And in these guidelines, they stated that there is moderate evidence that supports that for non-geriatric patients less than 65 years old, operative treatment for fractures with post-reduction radial shortening, like I mentioned, greater than 3 millimeters, dorsal angulation greater than 10 degrees, or intra-articular displacement of greater than 2 millimeters have improved radiographic and patient-reported outcomes. Conversely, they noted that there is strong evidence that suggests that operative treatment for geriatric patients age greater than 65 does not lead to improved patient-reported outcomes. The rationale being that malunion is functionally more well tolerated in the older age groups, despite differences or persistent differences in grip strength and range of motion when allowed to malunite, I guess. To further support these guidelines, there was a large review and meta-analysis published in the JAMA network evaluating the medium-term outcomes defined as less than 1 year, as measured by DASH scores and grip strength. So the DASH is a very quick survey that's always good to have a copy of in the hand in the clinic if you take care of any patients that present with hand and wrist problems. There is a mini DASH score that has been compared to the full DASH. It's just the same. It's the same questionnaire developed by the same people. It just has fewer questions and is found to have the same sensitivity for detecting disability. And I find that it's very, very useful for initial evaluation as well as tracking progress as patients return to clinic. The meta-analysis essentially concluded that when comparing operative and non-operative treatment of distal radius fractures in adults, there was a significant benefit in DASH scores and grip strength in the operative cohort. Notably, they did perform a subset analysis, including patients that were only 60 years and older, and there was no difference in DASH scores and grip strength between the groups. But they did have a higher risk of complication associated with surgical intervention. And taken as a whole, the authors concluded that the younger patients are the most likely to receive benefit from surgery, in lines with the guidelines published by the American Academy of Orthopedics and the Society for Surgery of the Hand. 2 additional studies published in the Journal of Hand Surgery and the Journal of Bone and Joint Surgery over the past 2 years elaborated on some of the complications that complication rates and outcomes between non-operative and operative cohorts in both the elderly and non-elderly populations. And specifically, I think that these studies were useful because they assessed for secondary surgeries and what types of surgeries these patients underwent. But notably, they were both large database studies and did not have any functional measures like the DASH or grip strength. So those 4 studies taken as an aggregate, I think are a good outline of my decision-making algorithm and the way I try to tailor the surgical interventions and an individualized approach. Though I will say from just the practical standpoint, there are a fair number of patients who present with these fractures, and even after going through all the pros and cons, risks and benefits, they really select surgery just based on the fact that they don't want a crooked wrist. And I'm happy to oblige in that scenario as long as they're well informed of the risks and benefits of surgery. So the functional improvement, I think we can say with a reasonable amount of certainty that in the younger patient, there is a benefit as evidenced by those DASH scores and grip strength. But the second question, when considering who and why patients need these operations, the incidence of secondary procedures to either correct malunion or other problems becomes, I think, of considerable importance. So in the 2 DeGeorge studies that I just put up, patients greater than 65 years of age had about a 50% reduction in the need for secondary procedures if they pursued operative intervention at the time of injury. For non-geriatric patients, this difference was even more dramatic, and patients who pursued non-operative intervention for distal radius fractures had a 5-fold increase in the need for secondary procedure. So then you might ask, well, what secondary procedure are we talking about? Well, in the non-geriatric population, carpal tunnel release was the most common secondary procedure pursued for patients who had non-operative management of a distal radius fracture. And in my mind, this is owing to a structural issue, most likely a well-tolerated malunion in a young patient that changes the biomechanics of the carpal tunnel owing to it, I guess, distortion, you could call it, of the distal radius. In the elderly population, and then what I think that the main thesis and the main point I want to drive home for distal radius fractures is that malunion and radial shortening cause symptoms. And in the elderly population, it was found that in the operative cohort, there was a 50% reduction in malunion rates. So in my mind, that's the most compelling reason to pursue surgery for those patients. It's not necessarily that they'll never heal their bone, but it's I think at this point very difficult to ascertain without any sort of guidance on stability and instability who's going to develop a symptomatic versus a not asymptomatic malunion. And one of the things that really stood out to me in these 2 studies is they were unable to define secondary procedures in the geriatric group. I think that this probably had a lot to do with the fact that radial shortening and that ulnar variance is treated through different modalities. Sometimes, we'll treat it with steroid injections. Sometimes patients will get a radial shortening. Sometimes they'll get an ulnar shortening. Sometimes they'll get hand therapy. And so there's not one CPT code that you can put into a database that'll tell you exactly how many patients had their malunions treated. Whereas in the younger patient cohort, there are two codes for carpal tunnel release. So back to our patient and why I chose to pursue surgery. So we can see, like we've discussed, he's got significant dorsal angulation and radial shortening. So now to the right, he presented with the films on the left immediately after injury. After reduction in the emergency department, it actually doesn't look too bad. He's got restoration of his volar tilt to neutral. So he no longer has dorsal angulation of greater than 10 degrees. His radial height has been restored. He's now ulnar neutral. And so I think that you could make an argument for this patient that he could be managed non-operatively in casting. This particular patient, as I mentioned, requested surgery. But one of the things that is very troubling with these radius fractures is that there is no consensus on how you define stable versus unstable fractures. So oftentimes we'll pursue non-operative management if the patient chooses to do so. And after a couple weeks, we'll slowly watch his radius start to shorten. And then all of a sudden now, instead of doing a fracture in the acute period, you're 6 to 8 weeks down the line. And now you're doing essentially a radius malunion with corrective osteotomy. So why do patients need an operation when it comes to distal radius fractures? I think it can be summed up in one bullet point. You're trying to prevent malunion and subsequent symptomatic radial shortening. So then what happens when, despite our best efforts, patients still use radial height and become symptomatic? This radiograph in the middle demonstrates volar plate placement for a distal radius fracture. Despite the best efforts, the patient is still ulnar positive rather, and patients will usually come into clinic complaining of ulnar-sided wrist pain. So on exam, if you ulnar deviate them and load that ulna, it'll bump into their carpal bones and the patient will experience pain. So there's several ways to treat it. Essentially, you have the relative difference in the length of the radius and ulna. So to correct that difference, you either lengthen the radius or shorten the ulna. Now, I will say that in an entire year of doing these types of surgeries, I did not see one single radius corrective osteotomy because it's a very difficult operation. And I think that most surgeons today will pursue an ulnar shortening osteotomy. So what you do is you essentially just remove the previous plate, assuming the bone is healed. You shorten the ulna by about 4 millimeters. You put a plate on there and patients actually do quite well. Tendon irritation and rupture are also known complications following both operative and non-operative treatment of distal radius fractures. The X-rays on the left demonstrate what's known as the SUM classification for volar plate placement following distal radius fractures. The red line is the volar critical line. And so you can tell progressing from left to right, that plate is getting more and more prominent. The important thing to keep in mind there is that the flexor tendons to the hand pass directly over that red line. So the more volar the plate is, the higher the risk of flexor tendon irritation and eventually rupture are. On the right, you can see that an inappropriate screw length has been selected during plate fixation, and the screws can actually come out of the back of the bone, causing irritation to the EPL tendon, notably as it courses around Lister's tubercle to go into the thumb, and it can be can fray and eventually rupture. The average time to rupture is about 9 months, but is reported as late as 10 years. So oftentimes these patients will report or present to their primary care physician with just swelling, tenderness, and they don't really always make the association between their surgery and the problems that they're having now. So a lot of the times that I've seen, patients with tendon ruptures will actually come to our clinic after their PCP has caught it. So any tenderness, crepitus, or pain with finger or thumb motion following distal radius fixation warrants investigation with an ultrasound and referral back to the surgeon, whichever surgeon did the initial operation. So one final critical look at my patient, JH. So as I mentioned, I went ahead and I fixed his radius because of the radiologic parameters and his overall active lifestyle. I thought that he was at high risk for continued radial shortening if we treated him with non-operative casting. And so on the left, I think my plate is well centralized. The screws are out of the articular fragment. I do notice that radial styloid screw is a little bit long. Fortunately, there are no tendons that are going to cross over in that area, so I think that'll be fine. But potentially more clinically relevant on the lateral view to avoid going too far in front of that volar critical line that we just discussed. I elected to keep my plate a little bit proximal. And so what you want is those distal screws underneath the joint surface to serve as a buttress and just hold the articular surface up. And I am a little bit worried with him that in the future he's going to settle and have a little bit of radial shortening, but I think that with the plate there, he won't form a symptomatic malunion, which is ultimately, as I mentioned, the goal of the operation. So that was a conscious decision to trade off a little bit of settling of the articular surface to minimize the risk of tendon rupture for him. So additionally, patients present to our clinic with, or to your clinic with radial sided wrist pain. They say, you know what, I don't know what's going on. I can't remember a specific history of trauma, but I tell you, my wrist hurts right here. It's right between these two tendons. And you say, oh, that's great. I know exactly what's happening. You've got pain in your anatomic snuff box. You've got a scaphoid fracture. So I think this is the scenario that's probably more common in the primary care setting. In contrast to distal radius fractures, which can have fairly dramatic deformities, prompting many patients to seek care in the emergency department, scaphoid fractures, by contrast, take on a more insidious course, resulting in delays in care that could lead to potentially debilitating problems and avoidable complications. Patients, as I mentioned, will usually present with pain on the radial side of the wrist. There's typically a history of trauma, such as falling on an outstretched hand. Oftentimes, this will be during non-competitive sports-related injuries where there's no team doctor or trainer present to evaluate the patient. It should be noted, however, that a very common presentation for for scaphoid injuries are in young men in their 20s to 30s who have a history of playing, football in high school. They present with this dull nagging pain in their wrist. They have no recollection of injuring themselves in the recent past. But if you ask them, they'll say, well, when I was a junior in high school, I was playing in a big football game and I fell and the trainer said I sprained my wrist, but I just put a splint on and kept playing through it. It's a very common presentation for scaphoid non-union that I think always has to be in the back of everyone's mind when radial sided wrist pain makes its way to your clinic. So among carpal bone injuries, scaphoid fractures are considered the most common with an estimated incidence of up to 70% and account for just over 10% of all hand fractures. As I mentioned, these fractures occur more commonly in younger men, in contrast to distal radius fractures, which occur most commonly in older women. The most common mechanism is fall on an outstretched hand with the wrist in extension and radial deviation. And as I mentioned, presenting symptoms can be minimal, leading to a problematic diagnosis or misdiagnosis as a wrist sprain. Thus, a high index of suspicion for radial-sided wrist pain and scaphoid fractures in the setting of radial-sided wrist pain is necessary to ensure an early diagnosis and proper management and avoid some of the complications like non-union and wrist arthritis due to abnormal wrist kinematics down the line. To understand the pathology of these fractures, I think there are a few key anatomic points to briefly touch upon. Moving from left to right, the scaphoid is divided into three anatomic segments: the distal pole, the waist, and the proximal pole, with 80% of the scaphoid covered in cartilage. Waist fractures are the most common anatomic locations for the scaphoid to break, largely owing to the radioscaphocapate ligament, which crosses over the volar waist of the scaphoid, creating a fulcrum during injury. And I think that most physicians will recall from medical school that the blood supply to the scaphoid bone is tenuous. The major blood supply is the dorsal carpal branch of the radial artery. There on the right, it enters the scaphoid in a non-articular ridge on the dorsal surface and supplies the proximal 80% of the scaphoid via retrograde blood flow. Additionally, there's a minor blood supply from the superficial palmar arch, again of the radial artery, that enters at the distal tubercle and supplies the distal 20% of the scaphoid. But when considering this retrograde blood flow, it becomes easy to understand why proximal pole fractures have the highest risk of avascular necrosis, as this blood supply is disrupted further down in the bone. 4 views of the wrist are considered the standard to evaluate possible scaphoid fractures, not unlike the previous wrist radiographs that we reviewed for distal radius fractures. However, I wanted to point out that there is a specific view called the scaphoid view, in which the patient, PA of the wrist is obtained with the patient with a clenched fist and ulnar deviation. The point being, this separates the ulnar deviation rather separates the scaphoid from the scaphoid facet on the radius and allows better visualization of the proximal pole of the scaphoid, as denoted on the right, and allows you to see the distal pole, waist, and proximal pole without bony overlap. When performed correctly, adequate films have a sensitivity of up to 90%, but there can be significant limitations in the quality of these films due to which radiology tech is performing the x-rays, and probably more commonly patient discomfort. Scaphoid fractures can be obviously very painful, and asking the patient to ulnarly deviate their wrist causes significant discomfort. And so I think, practically speaking, one of the reasons that the plain films are negative often is just because we couldn't get the patient into the appropriate view. The overall incidence of false negative radiographs due to inadequate films or whatever is reported to be as high as 25%. But in a patient with an appropriate history and mechanism of injury with accompanying radial-sided wrist pain in the anatomic snuff box, an occult scaphoid or the clinical scaphoid should be our diagnosis until proven otherwise. Traditionally, the teaching was that these patients with negative initial imaging should be placed in a cast for 2 to 3 weeks and the x-rays repeated. However, this time delay can have significant implications for treatment and non-union. And currently, advances in imaging have made it such that we can avoid this delay in treatment, waiting for the fractures to become readily evident on plain films. MRI remains the most sensitive imaging modality to detect occult fractures, because edema within the bone is detected within hours of the injury. One caveat that I will mention, however, is that in terms of patient selection for surgery, CT scan is the best for characterizing fracture patterns. And so this becomes a significant consideration when accounting for the timeline between injury to actual treatment. So if you have a patient that gets injured playing a pickup game of basketball, thinks they sprained their wrist and presents to your clinic 2 to 3 weeks after injury, obtaining an MRI probably delays it another week. You get the results of the MRI, and before you know it, you're 8 weeks out from injury before they've seen a hand and wrist specialist. And we know from previous studies that when treatment is delayed by 4 weeks, the risk of non-union can be as high as 40%. Compared to non-union rate of 3% when diagnosis and treatment occur within 4 weeks. So I think in the primary care setting, I know that there's always the pressure to be cost conscientious, but in this particular injury, I think that aggressive use of advanced imaging is warranted. And I personally, even though MRI is the most sensitive for picking up scaphoid fractures, I would still probably recommend that CT scans be obtained, because I think you'd be hard pressed to find a surgeon that's going to make a decision to proceed with an operation based on MRI findings. I think most of us would get a thin cut CT scan of the wrist before moving on to surgery. So again, we ask ourselves the three pertinent questions when it comes to operating. Who needs an operation? Why do they need an operation? And what long-term sequelae are we trying to avoid? This is a figure demonstrating the Herbert classification system, which essentially divides scaphoid fractures into two groups based on their inherent stability. And determining who needs surgery essentially is a matter of distinguishing unstable from stable fracture patterns. So stable fracture patterns in this classification system include fractures of the distal pole and incomplete fractures through the waist. But practically speaking, if we recall that the majority of fractures are through the waist, we can see that the most likely stable fracture that we're likely to encounter is an incomplete waist fracture or a type A2 fracture in this classification. Though I am unaware of any study specifically defining the incidence of stable scaphoid fractures, I would surmise that it is low, and as such, continue to aggressively work these out. Answering the question of why patients need treatment is a matter of continuing down the course of the natural history of these scaphoid fractures. I've mentioned previously that scaphoid non-unions increase with delayed treatment greater than 4 weeks. And the figure on the left demonstrates a displaced scaphoid fracture with a intrascaphoid angle of 66 degrees and the so-called humpback deformity, which is defined as an intrascaphoid angle of greater than 45 degrees. Vast majority of untreated scaphoid or untreated or those that experience delayed treatment of fractures will follow a defined degenerative pattern progressing from acute fracture to non-union to eventually non-union with advanced collapse and subsequent carpal arthritis that is termed the SNAC risk for scaphoid non-union advanced collapse. So once we have diagnosed the scaphoid fracture and determined it to be either stable or unstable, how are these fractures treated? Cast immobilization remains an acceptable option for managing CT or MRI confirmed stable or non-displaced fractures of the waist and distal pole. Displacement defined as anything greater than 1 millimeter. So oftentimes in the literature, you'll find that non-displaced and minimally displaced fractures are used interchangeably. Just mention, since I didn't put this on the slide, that stable, non-displaced / minimally displaced fractures defined as displacement less than 1 millimeter are amenable to casting. And studies have shown that in these fractures, the waist can heal and form a union in up to 90% of cases with 8 weeks of immobilization. There are several options for casting, including above the elbow, short arm, with or without inclusion of thumb immobilization. However, meta-analysis and systematic reviews have failed to show any significant benefit of immobilization of the forearm, elbow, or thumb. Thus, immobilization need only to be performed distal to the elbow with the wrist in a functional position. And this may seem like a small difference, but when you consider that these casts need to be kept in place for up to 12 weeks, patient comfort becomes an important consideration. And furthermore, given the extended duration of casting, there is an argument for early operative intervention, even in stable fractures, as several studies have demonstrated a decrease in overall cost and immobilization times. So there are several options for the fixation of scaphoid fractures, but far and away the most common is a single headless compression screw placed down the long axis of the bone, extending from the proximal to distal poles, spanning the waist. And though surgery has not clearly been proven to be superior in terms of overall union rate for these stable fractures in comparison to casting, proponents of surgery will cite improved range of motion, decreased time to union and return to work, and cost of savings as reasons to pursue surgery. To the contrary, proponents of casting will state equivalent / acceptable outcomes and mitigation of postoperative complications as reasons to pursue casting. But I think personally, and I think most people feel this way, the treatment should be individualized to best meet the needs of your patient. For example, myself as a surgeon, I probably would get a screw put down my scaphoid so I get back to work faster. But patients that have a desk job typing, they might not have to miss work at all, even if you put them in a long arm cast for 12 weeks. So it's important to always keep that in mind when making these decisions. And so in the same way that I tried to summarize the reason to do surgery on a distal radius fracture, I tried to do the same in the scaphoid fracture. And I think that the main reason for doing surgery on scaphoid fractures is to mitigate the risk of non-union with subsequent progression to SNAC wrist, which has really no ideal forms of treatment. They're all varying levels of wrist arthrodesis. All patients lose grip strength. They all lose range of motion. And so preventing that from happening is, I think, the most important part of the treatment of these fractures. The diagnosis and management of scaphoid non-unions in of itself is an hour-long presentation, but I did want to just demonstrate the difference between, the acute intervention with putting a headless compression screw down the long axis of the scaphoid, which in certain circumstances, I've done that case in less than 10 minutes. Sometimes it's a little bit more difficult, maybe up to an hour and a half if you're struggling with the reduction, but the treatments for scaphoid non-union with avascular necrosis can include things like this video here, the mediofemoral condyle flap, where we actually take a piece of bone from the knee on its vascular pedicle and sew it into the radial artery. So I don't think anyone would sign up for that operation unless they absolutely had to. So again, I think that the most important thing for these fractures is to prevent non-union and having to do these more aggressive surgeries. So let's say we don't, and the patient develops a non-union. The progression to advanced arthritis in the so-called SNAC wrist proceeds in a very predictable fashion. Stage 1 on the left is just impingement of the radial styloid by the distal segment of the scaphoid, causing localized arthritis. If the non-union and arthritis is caught at this stage, which it almost never is, a relatively minor procedure, radial styloidectomy can be pursued. But for stages 2 and 3, denoted by the middle and the right picture as the arthritis progresses, are always treated with some varying degree of wrist arthrodesis. So understandably, loss of motion and strength in young patients, which this typically affects, is not ideal. So just to summarize, wrist pain is a common presenting complaint both to specialist clinics and also primary care physicians. The diagnosis can often be challenging, but knowing when to escalate care to operative intervention can mitigate some of the secondary problems that these patients face. There's my references, and happy to take any questions or.
I don't see any questions in the chat box, but anybody who wants to make a comment, or if you have a question, please feel free to unmute, or you can put it in the chat box there if you'd like.
I have a quick question.
Sure.
So you mentioned the scaphoid fracture for the stable, minimally displaced. When you do decide to do casting versus getting, I guess, operation, having the reduction, how often do you follow up with the radiographic studies?
So that, I think, in comparison to the distal radius fracture, where you're checking for radial shortening every couple weeks, typically you can space out the radiographs for scaphoid fractures to be, I mean, I'd do it like once a month, because you're already sort of committing yourself to that treatment. So it's not necessarily the same interval. So once you establish, and keep in mind, for radius fractures, we have difficulty telling which ones are stable and unstable. There's a LaFontaine criteria that was developed in, I think, the 60s or the 70s that a lot of people will use as a guideline, but there's really no way to tell which radius fractures are going to shorten. Now, by comparison, you assume that you're casting the appropriate fractures. So you're not really checking to see if they're collapsing, because if they're unstable and at risk for collapse, then you wouldn't do casting in the first place. So it's a little bit different and nuanced in that regard. So personally, I don't bring patients back every week to get repeat x-rays, because presumably you've chosen the right treatment for the right fracture pattern. So that can be a little bit challenging, and obviously there are errors in judgment that can be made, but I think if you choose the right fracture patterns, you don't need to necessarily get weekly x-rays or anything like that.
Thank you.
Mm-hmm.
Do we have any other comments or questions for today? Okay, well, I'm not seeing anything else here in the chat. I did put the link there. If everybody could please help us out and give us some feedback on today's session, as well as for Dr. Martinez. And want to thank you very much, Dr. Martinez. I know you had a busy week, and appreciate you presenting for us today. And thank you everyone for joining us. Thank you so much.
Thank you, guys.
Everybody have a good day.